Roll call. Jeff, would you take that for us?
Yes, thank you, Chairman. Sheriff Youngblood. Here. James Miller. Here. Kathy Prout. Here. Bruce Peters. Here. Dr. Lyon. Here. Brian Marshall. Excuse me, Chief. Present. Aaron Moses. Present. We have a quorum.
Outstanding. Proceed to the consent agenda. All items listed with the CA are considered by division staff to be routine and non-controversial. Consent items will be considered first and approved in one motion if no member of the board or audience wishes to comment or discuss an item. If comment or discussion is desired, the item will be removed from consent agenda and heard in its listed sequence with an opportunity for any member of the public to address the board concerning the item before action is taken. Okay, going through our agenda, I see a CA on item 5, which is the approval of the minutes. I see a CA on item number 12, which is miscellaneous documents for information regarding the EMS fund report. Anybody in the public who would like to make comment on either of these items, now's your opportunity. Seeing none, I'll bring it back to the board for comment and approval of the CA agenda. We have a motion and a second. All in favor say aye. 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 Opposed? Okay, moving to subcommittee reports. There are none. Public comments. This portion of the meeting is reserved for persons desiring to address the board in any matter not on this agenda and over which the board has jurisdiction. Members of the public will also have the opportunity to comment on an agenda item as they're discussed. Let's open it up for public comments on anything not on this agenda. Anybody like to comment on anything? Great, thank you. We'll continue moving on. Public requests, item number 8, accreditation policy. Jeff. Oh, Kern Medical, who's going to take that over? Do you?
Thank you, Mr. Chairman. I believe Paula Isbell requested time to speak to the board.
If you'd please just state your name. Yeah, sure.
My name is Paula Isbell Copper. I thank you for the opportunity to address your board today. I realize your time is valuable, so I've prepared a statement in an effort to be concise. I heard you guys are shooting for this. Should only take about an hour and a half or so.
You're going to get lonely.
Yeah.
And I'd like to clarify that while I am employed by Kern Medical as well as Dignity Health, I'm not here as a representative of either organization. I'm here today to speak in regards to the changes made to the accreditation policy to add the requirement for live scan DOJ background checks and FBI background checks for mobile intensive care certification, also referred to as MICNs. As a former employee of this department, of the Kern County EMS department, I've met many nurses in my capacity as the instructor of the MICN program. After becoming a nurse, I moved over to the emergency department at Kern Medical and also accepted employment with Dignity Health. Because of my previous role with the EMS department, I have often been approached with questions and clarification in regards to EMS policy. For those who may not be familiar with the function of an MICN, kind of an obscure little niche of the EMS system, I'd just like to give you a brief background on what an MICN does. An MICN is a registered nurse employed in the emergency department who answers the radio for ambulance traffic. The MICN is able to provide direction to EMS personnel based off of approved EMS protocols. The MICN may not provide direction outside of these protocols. EMS personnel are able to function based off of these protocols without the direction of an MICN if they're unable to establish radio contact. An MICN does not have protocols that would allow the nurse to function outside of the hospital and also does not have protocols that would allow the nurse to touch or treat a patient in any way. In order to become an MICN, the RN must maintain current licensure as a registered nurse in the state of California, maintain current certification in advanced cardiac life support, submit a photo ID, complete the department application, which includes disclosures of criminal convictions as well as negative license actions, attend an 8-hour class and a 16-hour ride-along, and pay fees of $207. There has been some confusion as to the requirement for LiveScan for MICNs, and it is commonly assumed that a DOJ FBI background maintained by the BRN fulfills this requirement for a background check. Even the hospitals who employ RNs do not require a DOJ LiveScan background separate of the requirement for the Board of Registered Nursing. So this is kind of unusual. Many people who saw this requirement assumed that I've got a DOJ background on file with subsequent reporting, so that's what they're referring to. We have backgrounds. The BRN in the state of California is responsible for investigation and disciplinary action against an RN's license. In order to hold an MICN certification, one must have a valid RN license. Moving forward with the issue at hand, on December 7th, 2017, a slide was presented at the EMS System Collaborative meeting with 4 bullet points that listed changes to the accreditation policy. Changes listed were as follows. Multiple individual policies were combined to one document. The policy was updated to clarify that all levels of accreditation, all levels of certification had to be accredited to operate in Kern County. It was updated to require LiveScan for all levels of accreditation, and the changes were effective January 1st, 2018. As the implementation date was already listed, it appears that this presentation was informative and not really open to discussion or public comment at that time. The new accreditation policy was implemented, I'm unclear. Looking at the date on the policy, it says February. In the slide, it said January, but sometime early 2018, 21 days after the initial presentation in the EMS System Collaborative meeting. This was presented to MCAB in the February 2018 meeting for a receive and file type motion. The action really went without notice, mostly due to the fact that the affected parties had not come up for recertification or attended an MICN class until the first MICN class was held in March of 2018, March 21st, after your last meeting. And then it created quite an upheaval. A lot of MICNs had a delay in their recertification and their certification because they were unaware that they needed to meet this LiveScan requirement. They felt that they had already done that. I guess because I am accessible in multiple ERs, a lot of the people brought their displeasure to me, and I said, well, let me ask some questions because I can't answer to what the intent behind that policy is. So after some back and forth with Jeff and I, still love you, I was invited to address my concerns before your board today. Well, I'm unsure if this action was actually in compliance with the spirit of the Brown Act. The one thing I would say in confidence is that there was a lack of communications, and there are many questions that remain unanswered in the minds of the MICNs affected by this policy. Many MICNs have expressed the intent to allow their MICN certifications to expire, and others who are not currently certified have expressed the intent to not seek certification. I think that that would be a huge loss of collaborative working environment between the departments if everybody simply let it go, or if they only participated under duress by their employer. I mean, it would be nice to have a cooperative, positive working relationship. I would like to point out that in order, you know, it seems trivial. People said, it's just, you know, it's just a one-time thing. You know, we've been taught to protect our personal information. And it seems trivial, but an RN, it's not. It's a one-time fee, a fee borne by the RN. But I'd like to point out that in order to function as an RN, we're not just RNs. We have to maintain current licensure in the state of California. But minimum certifications that we have to have is current advanced cardiac life support, pediatric advanced life support. We have to have some form of training in evasive maneuvers for combative patients. We have to have our stroke certification. We have to maintain fit testing, TB testing, annual skill signs off. I printed out my mandatory education list from the beginning of this year. For one facility alone, it was 6 pages. So it's not just a simple item. And then as far as the cost, many of these courses and certifications that we're required to maintain, some are borne by the employer, many are not. Myself, all of my certifications come due at the same time. So $500 covers approximately 2 of them. The rest are out of my pocket. Some of the questions that have been brought to me, and I think they're valid questions, have been, what is the actual purpose for collecting this information? I know in the presentation that was presented to MCAB, it was kind of a vague statement that to avoid criminal convictions slipping through the cracks and to reduce liability of the EMS medical director, who I'm meeting for the first time. But that's not real specific. Specifically, what is the concern? Have there been liable situations created by an MICN? Keeping in mind that the MICN, while functioning within the hospital, is functioning under the umbrella and liability of the hospital where they're employed, as well as their medical director. We're not functioning outside of the hospital. So I'm not sure what liability or what situation may have occurred that could have provoked this action. We're not clear on it. And then also, how will this information be used? Does the EMS department intend to bring enforcement action against RNs for criminal activities? Does the EMS department intend to hold the RN to a different enforcement standard than the BRN? If it's the same enforcement standard, then why the need? If we get in trouble, probably before we sign our booking forms, the BRN has already been notified, who immediately notifies our employer. Being as we're required to maintain a valid RN license, if there's an action against our RN license, by default, our MICN certification becomes invalid. If the BRN has determined that, while criminal activity may have occurred, we're not a threat to public health or safety, therefore we will maintain our license during the process of the investigation, and we're allowed to continue in our employment in the emergency department, would it not be considered also safe to continue to allow us to answer a radio? There's concerns about how this information would be stored. And then also, as far as the liability, I guess the question would be, what form of liability do you actually anticipate, and how would that be mitigated or avoided in some way by having a DOJ background? For example, if you knew I had a 10-year-old DUI, I don't, but if I did, and you were aware of that, would that change my ability to answer a radio as an RN if I had been through the process, the disciplinary process, through the BRN? So I don't want to go on. I know you guys, your time is precious. I hope I've been clear in my presentation and in some of the concerns that have been expressed to me regarding this requirement for DOJ backgrounds on MICNs. And in closing, I would like to respectfully make 2 requests. I would like to request that the topic of the requirement for live scan background checks for MICNs be reopened to discussion and public comment. And 2, I would like to request that the requirement for live scan background checks for MICNs be suspended until the topic has been discussed and put out to public comment.
Thank you. Could you restate your name again?
My name is Paula Isbell Coffrin. I'll spell the last name, C-A-U-G-H-R-O-N.
Outstanding. Are your comments for the record? Could we get a copy of those?
Absolutely.
We'll just keep those on file.
Sure.
Thank you very much, and I think you did raise some valid questions. Thank you. Anybody else would like to talk on item number 8, accreditation policy? Anyone in the public would like to talk about it? Okay, I don't see anybody who wants to talk about it, so we're going to close the public hearing, and we'll bring it back to the board And I think, Jeff, you can start us off with a review of what you heard and maybe answer some of the questions that were offered.
Thank you, Mr. Chairman. The accreditation policy, as it reads now, was, I believe, followed the Brown Act exactly. It was publicly noticed on an agenda for the System Collaborative, at which point it was open for discussion during that System Collaborative meeting. It was then brought before this board again on another public agenda that was posted. It was discussed here publicly, and it was asked if anybody in the audience had any questions regarding this accreditation policy. So I believe we did follow the Brown Act. In regards to the purpose for the live scan, we have a medical director, and Health and Safety Code 1797.56 specifically gives the medical director the authority to authorize MICNs, mobile intensive care nurses. He has the power, and EMS has the authority to create a system that protects the public and the medical director's license. We made a decision at EMS in 2017 that we wanted all locally accredited individuals in our county who are operating on the medical director's license to go through a live scan for us. A live scan, if you're not familiar, is just an electronic set of fingerprints that registers you with our system, with us. I understand that at the BRN, to hold their license, they have to go through a live scan. But the BRN does not communicate with EMS. And in my experience, they are notoriously lenient when it comes to violations of the law. We want to make sure that anybody who receives a local accreditation is not breaking the law. Since the implementation of this policy, we have accredited 93 total individuals covering all of our accreditation levels, including EMT, paramedic, MICN, and 53 of those were MICNs. Out of those 53, we had found numerous individuals who had recent criminal violations. So over the years, these had not been reported to us. BRN, as I said, does not report to us. So clearly, under Health and Safety Code, the medical director and EMS has the right to create a system that protects the public and the medical director's license. And finally, sorry. I will find it. Penal Code Section 11105.3 provides any human resource agency the ability to live scan and do a background check on any individual who is requesting a certification, employment, or even volunteering. So I believe that we followed the Brown Act. I believe that we are justified in requesting the live scan for EMS. In response to her statement of what's going to happen with the information, we don't store the information. The live scan goes to the Department of Justice, and we only receive notification if that individual violates the law. According to the FBI, once that occurs, if it is dismissed and the case is closed, we must destroy that document, and that's what occurs. So I believe that we are validated in our actions here to protect the citizens and the medical director's license.
Thank you, sir. GK, would you like to offer comment on Brown Act implications, and are we clean with all that?
Thank you, Mr. Chairman, members of the board, through the chairman. I've had an opportunity to review the process. I would concur with the director that the Brown Act was followed, that this element is within the jurisdictional purview of the local EMS. It was properly agendized on at least 2 occasions with the opportunity for public comment. And my understanding is that prior to a vote on the motion to receive and file, there was a request for public comment. So I think the Brown Act was covered completely. And I think that, again, as Mr. Ferris has indicated, this is within the jurisdictional purview, it's within the law, and it appears to be, from our review, a prudent policy. Thank you.
Thank you, sir. Okay, we'll open up the board for comment and consideration. Anybody on the board?
Mr. Chairman,
Yes, sir.
representing the
Bruce.
hospitals, and her current and also her other employer, I concur with many of her concerns, and I think, I don't recall whether I was at the meeting in February. If I was asleep at the switch. I mean, I don't recall this being brought to my attention. I don't attend the collaborative meeting. However, I do recall some of the implications now that I've been hearing about this today, where particularly in March, April, we had trouble getting enough people certified as MICNs in order to staff the hospital. To me, this policy appears to be a belt and suspenders kind of thing. The fact that the BRN may or may not have a reporting mechanism to EMS is, you know, in my mind, not the issue. An RN who works in a hospital, as Paula pointed out, has a lot of scrutiny placed on them through a lot of different agencies that we have to do through our background checks. And I would say that if they continue to work in the hospital, even if there is some sort of what's probably minor criminal violation, we're not going to have too much trouble with putting them in the MICN role. There is cost to that. I think it's an over-regulation and over use of department's resources to require this. And I would personally, I believe, speaking for the hospitals, recommend that this be reopened for further consideration. I think it's too much.
Thank you, Bruce. Any other comments?
How many?
Yes, sir.
You said how many that we had several criminal allegations or?
Out of the 53, I don't have the exact count, but I know that we had.
Would you know if it's like less than 3 or more than 3 or?
More than 3.
No. Thank you very much. Any other comments from the board? I got a couple questions. I thought you brought up some good points, but I'm not, you know, if, let's say, one of the points you brought up was, let's say that, maybe Bruce, I can ask you this question as a matter of protocol. Let's say someone does have a DUI and, you know, 10 years ago, she doesn't, but she, you know, it's a really good instance, and she came in, how would that be reviewed by the persons who are issuing the certification?
Well, if, you know, fundamentally, for any nurse to work at a hospital, they've got to get through the BRN. The BRN has a process for people to be, you know, a well-being committee per se that helps people continue to hold their license. And we are comfortable, you know, I'm not saying I'm 100% a fan of the BRN, but as far as protecting the public, and I don't find them to be that lenient as far as nurses who either have issues. We report to the BRN often for, you know, diversion appears to be one of our biggest issues that we have in the hospital, diversion of drugs. They jump on that with both feet, and they often do not maintain their license. So I would sort of question the significance of what this additional screening and oversight would add to that.
So it's a judgment call.
It's a judgment call, but you've got to have your license, and it is not easy to maintain if you've had significant issues that you've had personally, either criminally or anything
Thanks.
like that.
Jeff, how many MICNs do we have?
I don't have that number.
Give me a ballpark.
200.
Okay, so 200. Miss Isbell? I got a question for you, and maybe you could squeeze in your comment with my question. If you could come back to the mic, please. As long as it's a short comment. My question to you was, you made a statement saying that you know several MICNs that are not going to recertify or either flat out refuse or considering. How many are you talking about?
Well, all of them have said that, whether or not they will.
All of them, 200, have said what to you?
Well, no, not all 200. The ones that I have discussed, that have brought issues to me, which is probably about 12.
Okay.
I work sporadic shifts, so I haven't been in contact with all the MICNs through all the hospitals in the county. But with the hospitals I do work at, the general feeling was 100%.
Of the people you talked to resented the
correct.
fact that they had to recertify.
Correct.
Okay, and now
Absolutely.
you can make your comment, as long as it's
No,
short.
I just had a question. You mentioned that, you know.
Yeah,
that
ask a
there-
question to me, please.
Okay, well, no, of the MICNs who did come up with criminal activity on their backgrounds, how many actually met the denial revocation standard to be denied an MICN certification?
Thank you, we'll get you that answer.
Thank you.
Jeff, you want to take a shot at that?
Sure, none.
Thank you.
But we investigated them. We asked them to come down, interview them, talk to them, and completed the investigation on them.
Okay, thank you. I'm looking for other comments from other board members or thoughts. Or a motion or something.
Could I ask County Counsel a question?
Yes, sir.
Mrs. Cochran's husband is employed as a helicopter pilot by me, and he's also the president of the Deputies Union. Should I recuse myself?
I think we just have a conservative approach and say yes.
Lucky bastard.
Gentlemen, sir, employee.
He knows me, he wants shot too.
I go too.
All those want to be refused. No, I think that would be the safest approach, and I think that you have a relationship with the
And I probably should ask before we started, should I leave the room or just be quiet?
No, I don't believe so. I think for purposes of discussion, it's fine to hear from all board members. For purposes of decision, my recommendation would be use this gentleman because of your relationship with a family member. And with an employee.
Mr. Chairman, is
Sir.
there any action that needs to be?
Yeah, we need to take, the action is to, what is the action?
Reopen and
It's a
suspend.
public request.
Yes, she requested, Ms. Isabel requested that the policy be reopened for public comment and discussion, and that it be suspended pending that discussion.
Okay, so the question before this board is, do we want to reopen it? One, and do we want to suspend it? Two.
That's correct, sir.
In order to do either of those, we need a motion from the board, seconded, and a vote.
That's correct.
So that's the action. Or if there is no request for that to occur, we just do nothing and move to the next item.
I believe there would need to be a request to deny her requests and move on.
Okay. So we need a motion either way, either approval or disapproval. Is that true, GK?
I'd like to disagree with my esteemed director. I don't believe that you need a motion. She's made a request, you need a motion to move on her request, but I don't believe you need a motion to deny it.
Is there any motion to move on the request by the young lady, Ms. Paula Isbell? Last name, I forget. Is there a motion to move on that? Hearing no motion, we'll move on. Item number 9, unfinished business, has been continued to November 8th. Brings us to item number 10. There are 3 elements to item number 10, new business. A is impact of ALS and BLS handoff protocols. There's a motion to receive and file. Mr. Ferris.
Thank you, Mr. Chairman. In 2017, the EMS division recognized the response time standards were not being met in several metropolitan zones throughout Kern County. Not only did this affect the ambulance provider's ability to meet their contractual duties to EMS, but it also created a potential public health concern for the communities that they serve. In response, the EMS division initiated quality improvement efforts to develop long-term solutions for this issue. One area of improvement that EMS identified was the Metro or Metropolitan Priority 1 response times for EOA 4, that's downtown Bakersfield, and EOA 5, where we're sitting right now. These areas service the majority of the metropolitan Bakersfield. Ambulance patient offload times and increased call volumes were acknowledged by the EMS division as possible contributing factors to the extended response times, particularly in these metro zones. In order to mitigate compliance issues within these metro areas, EMS created the ALS to BLS handoff protocol and direct to triage policy. The theory behind these changes was to allow advanced life support units to transfer care of lower acuity patients to either basic life support ambulances or EMTs or the hospital triage nurse. This would allow paramedics to bypass the emergency department, thus freeing up an ALS unit to respond more quickly to higher acuity patients. The ALS to BLS handoff protocol was adopted November 1st, 2017, for use mainly in the metro areas. As of May 31st, 2018, this protocol has been used 374 times by ALS crews. The impact of this protocol is very apparent, as response times immediately dropped in the metro areas and are now below the standards set forth by the ambulance performance standards. The direct to triage policy was adopted April of this year, and the data is not yet available for all of those calls. Since the ALS to BLS handoff protocol was instituted in November, all Bakersfield Metro Priority 1 responses have been met and are below the 8-minute, 59-second standard. If you look at Figure 1 in your packet, you will see a graph that shows the dramatic drop-off after November and then again in April. So between November 17 and May 2018, response times in EOA 4 decreased by 1 minute 28 seconds, and response times in EOA 5 by 50 seconds. Response times in EOA 4 have seen the most improvement. Before the adoption of this protocol, this EOA was non-compliant with response times to Priority 1. After November 2017, response times in this EOA dropped and remain consistent. That completes my report. For receive and file, and I'm here for any questions if you have.
Standing report, thank you, sir. Anybody in the public wishing to make comment on this item? Hearing none, I'll close the public hearing, bring it back to the board for a motion or a conversation. Motion would be to receive and file.
Second.
All in favor say aye.
Aye.
Aye. Opposed? Okay, move on to item number B, I think, correct? B, ambulance performance standards. Mr. Ferris.
Thank you, Mr. Chairman. The Kern County Ambulance Performance Standards established the minimum standards for ambulance services across this county. These standards are applicable to all contracted ground ambulance providers. These standards are directly referenced in the Kern County Ordinance Code Chapter 8.12 entitled Ambulances, and each agreement for provision of ground ambulance service executed by the county. Both the ordinance and the agreement contain basic performance provisions. However, the standards define performance requirements specific to ambulance providers. Originally written in 2006, the ambulance performance standards have been the yardstick used to measure ambulance service compliance throughout the county for the past 12 years. During that time, there have been significant changes to our system that are not reflected in this document. Examples include numerous changes to the emergency medical dispatch policies, increased use of basic life support ambulances, increase in population leading to higher call volumes, and the negative effect of the 100 call rule that was placed 12 years ago. In response to these and other changes to our system, EMS has spent many hours revising the ambulance performance standards to better reflect the needs of our system and of the citizens of Kern County. These changes include pointing the standards to the most current versions of policies, such as the emergency medical dispatch policy, implementing fines for failure to comply with the ambulance performance standards, and focusing on real-time response by removing the 100-call rule. I believe that the changes to the ambulance performance standards present a significant improvement to our EMS system, a real-time view of response compliance, a method to hold our ambulance providers accountable, and a clear path to the future. Therefore, it's recommended that the board approve the updated ambulance performance standards, and I'm available to answer any questions.
Thank you, Mr. Ferris. Anybody in the public wishing to make comment on item B? Mr. Hawkins, please introduce yourself and make your comments.
Fred Hawkins, Director of Emergency Services at Ridgecrest Regional Hospital. I only have one comment on one section, and it's, I would have done this earlier, but I wasn't aware this was on the packet. But on item page 2D, is regarding transportation of inter-facility transports of patients from one facility to the other. In this section, it allows for two exclusions where the ambulance provider does not have to transport the patient. Item one is the ambulance provider will not be reimbursed for services performed, and for instance, no pay available. Or two, the transferring physician fails to demonstrate that there is no general acute care hospital or specialty hospital in Kern County that is capable of accepting and providing appropriate care for the patient at the time the transfer is required. And for a small rural hospital, critical access hospital, this is a major issue to us. We've had this problem in the past where, for financial reasons, we've had transfers denied. And in some cases, we had to guarantee payment to open up beds and get patients out of the emergency room or moved. And in today's world, our case managers and social workers spend hours on the phone, making phone calls to hospitals all over Southern California for certain cases like bariatric patients and dialysis patients. So when we actually get a bed, having a delay in an ambulance transport is a major issue to us. We would hope to be able to come up with better language than this, because if we have a patient who, under the opinion of two physicians, is medically necessary to be transferred from one hospital to the other, the financial situation of the patient should not be an issue. That's the whole idea behind around restricted ambulance market. You have the good and the bad, and currently we're a single provider system. So I would hope that this area can be either deleted so we can come up with better language. I don't want to hold up the whole document in any way, shape, or form, but this is something for rural critical access hospital is very important to us.
Thanks, Mr. Hawkins. I was late following you. What sentence are you talking about?
Page 2, section D.
Section D, the entire section?
Yeah, D and the
Got it right.
subsection of
Okay.
1 and 2.
Thank you, Mr. Hawkins.
Thank you.
Appreciate it. Any other comments? Mr. Ferris, over to you.
Thank you, Mr. Chairman. Section D, in its entirety, has been in this document for 12 years. It has been, to my knowledge, a non-issue to this point. We at EMS have received no calls or complaints or issues regarding this section. What I did change in here was just the verbiage, the language, to be more clear. It has always said the same exact thing. This is standard language throughout the state. I polled my colleagues in all LIMSAs throughout the state over the past few days, and it is common to multiple LIMSAs up and down the state. Some LIMSAs actually mandate that the hospitals, if the patient can't pay, that the hospital must pay the ambulance provider, and then go after the patient or the insurance themselves to recoup that. I think that it's not fair. EMS's viewpoint is it's not fair or appropriate to force an ambulance provider to go long distance, and these are only calls that are leaving a hospital to go out of county, and that does not happen on that regular of a basis. So it would be, for example, from a local hospital here to San Diego. If the patient didn't have any, if there was no payor, the ambulance provider has to eat that entire trip. And we don't believe that that's fair or appropriate for our local providers. So we give them the right under those conditions, if there's no payor, that they can refuse that long distance transport. Those are the only calls they can refuse.
Let me ask you a couple questions. Is that change new? What you just said new?
No, sir, it's been in there for 12 years.
So there's no change to paragraph D. So I don't understand what Mr. Hawkins is concerned then.
The only change is I reworded it so that it made more sense to me, but it says the exact same thing. that it has said for 12 years.
Mr. Hawkins? Real quick. I don't want to belabor this thing.
No, that's okay.
I just want to make sure that you're
Well,
clear with what he's
First
saying.
of all, this document wasn't circulated for opinion or
Okay,
input.
fair
so
enough.
We would have brought this up. And it has occurred. Remember, we had a conversation in San Diego at the EMS conference regarding this issue, where we had a patient we couldn't move. Here's the issue. We are restricted by the current operating system to one ambulance provider. There's only 3 ambulance providers in Kern County, 3. So if A is not going to run it for financial reasons, why would B or C run it, which is the option we were given? It's not going to happen. So then what do? If all the ambulance providers turn the patient down for financial reasons, what do? We put them in a corner and tell the family sorry?
What have you done in the past?
Well,
If there's no
actually had
change.
the last one I had to personally, which was about a month ago, was a transfer home on a patient, hospice patient. We had to guarantee payment for them to come get the patient, because we had to move a patient out of the beds. We only had 25 licensed beds under critical access. So to get a bed free, to get a patient out of the emergency department, I had to guarantee as a hospital bill on that ambulance patient in order to free up that bed. And that's not something we can easily do, and we don't want to do, and don't want to get into that practice. But this has happened. You know, we ran into the situation on New Year's Eve. There was no critical care ambulance in the county. None. No ambulance service available for critical care. We made over 100 phone calls to hospitals trying to find a bed for bariatric patients and couldn't get the patient moved. There was no ambulance available to move the patient. And because of weather, we couldn't go by air.
Thank you,
Rural
Mr. Hawkins.
hospitals, we can't operate like that. So if we had known this was going to be an issue, we would have brought this sooner, but it wasn't brought to our attention. So.
Thanks, sir. Anything else? Go ahead.
This section, the ambulance performance standards is ground ambulance only.
Any other comments or action from the board? I need a motion, one way or another, to, the motion is to approve. Motion to approve. All in favor, say aye. Aye. Opposed? Moving on. Item 12C. 10C. I don't have my glasses. Something commission decision.
Thank you, Mr. Chairman. Health and Safety Code 1797.254 states that local EMS agencies shall annually submit an emergency medical services plan for the EMS area to the EMS authority according to the EMS systems, standards, and guidelines established by the authority. Such a plan was filed with the California Emergency Medical Services Authority in 2012. This plan was denied by the authority, and who indicated that the transportation section was at issue, and they disapproved the entire structure of our EOA system. The EMS director at the time believed that the EMS plan was valid and appealed the state's denial. This marked the first time that a local EMS agency filed an appeal against the State Emergency Medical Services Authority ever. The Emergency Medical Services Authority had no official due process procedure in place, so the appeal had to be put on hold in order for the state to create a due process system within the law. In March of 2018, the appeal was finally heard in this room by an administrative law judge. After 3 days of testimony and filings of amicus briefs by both attorneys, the judge took the case. On May 18, 2018, Administrative Law Judge Samuel D. Reyes issued his proposed decision. In the proposed decision, Judge Reyes upheld Kern County's exclusive operating areas 2, 3, 4, 5, 6, 8, and 9. However, he did agree with the state for EOAs 1, 7, and 11. On June 20th, 2018, the State of California Commission on EMS adopted the proposed decision by Judge Reyes. Due to Judge Reyes' decision and the adoption by the Commission, Kern County EMS will undertake the task of conducting a competitive bid process with the intention of awarding exclusive operating areas 1, 7, and 11 to the most qualified bidders. This process is expected to be lengthy and take possibly 1 to 2 years to complete. That concludes my report. I recommend that the board receive and file.
Thanks, sir. Appreciate it. Public comment. Anybody in the public wishing to make a comment on this issue? 12C. Seeing none, I'll close the public hearing and bring it back to the board for comment and consideration. The motion would be to receive and file.
I'll make a motion to.
We have a motion and a second. All in favor say aye. Aye. Opposed? Director's report.
Thank you, Mr. Chairman. I'm very pleased to provide an update on the EMS division, as 2018 is proving to be an exciting year for the system. Throughout the year, the EMS division continues to expand our services to Kern County by accepting new challenges, providing education, and participating in extraordinary events at both the county and state levels. Our system is constantly changing, requiring that we accept challenging tasks and expand our resources and capabilities. One challenge we are currently undertaking is the creation of the request for proposal that I just spoke to you about. Additionally, our division is being challenged to accept a larger role in Kern County's emergency preparedness process. In July, EMS personnel participated in the threat and hazard identification and risk assessment at the EOC to ensure that Kern County Public Health is able to apply for Homeland Security grant funding in 2019. This is the first time the county has been required to participate in this process. Furthermore, we are currently absorbing both the Kern County Healthcare Coalition and the Kern Medical Reserve Corps into our division. Throughout these programs, we will work towards establishing collaborative relationships with volunteer organizations and external healthcare entities to enhance our emergency response capabilities. This will allow our division to act as a liaison between multiple organizations, which will create a unified response to an emergency situation, thus protecting our communities in the event of a large-scale incident. We are still focused on improving the health and safety of our community by providing education. In an effort to keep our community safe, we continue to teach community members hands-only CPR, AED, and stop the bleed. So far this year, we have provided hands-only CPR training at the North of the River Summer Plunge, Community Partners Day in Golden Hills, Employers Training Resource, Kern County General Services, and the Kern County CERT team. In addition, we are identifying policies, procedures, and protocols that need to be updated or created in order to ensure the health and safety of the residents of Kern County. For example, in an effort to decrease response times for major metro areas, we implemented the ALS to BLS handoff protocol and the triage, direct-to-triage policy. Additionally, we currently have 3 new policies that are open for public comment that will have a definite effect on our system. They are against medical advice, paramedic preceptor, and paramedic first responder policies. Once they have completed the public comment phase, they will be brought here before your board for approval. Not only do we continue to educate our community members, but we also educate our EMS providers about the changes in the system. In May, EMS hosted a paramedic update class mandating that all accredited paramedics attend. It took a week to get all locally accredited paramedics through the class and up to date on all of the changes to the policies, procedures, and protocols. Lastly, our division has been involved in several extraordinary events at both the county and state levels. In May, we lost our longest-serving mayor, Harvey L. Hall. Shortly after his passing, John Surface contacted me and informed me that he had been receiving calls from ambulance companies throughout the state offering to send ambulances to assist during Mayor Hall's services. On Saturday, June 2nd, more than 26 ambulances responded some from great distances to provide emergency response coverage to the greater Bakersfield area, allowing Hall employees to attend his services. EMS worked closely with Hall ambulance staff, Kern County Fire, Bakersfield City Fire, and the Bakersfield Police Department to assure that the continuity of service to our community was maintained. To that end, EMS stood up our DOC, placing one staff member in Hall Ambulance's Communications Center, one staff member at the service with radio capability, and 4 staff in the office monitoring the system. Each paramedic and EMT that entered our system from out of the area were granted a temporary local accreditation by Dr. Lyon, allowing them to operate in our system. Hall Ambulance supplied them with radios, and they were each directed to contact EMS 3 when preparing to transport in order to assure that each patient was transported to the appropriate hospital. This operation was a huge success and resulted in no untoward occurrences. On August 1st, just after 8 p.m., the division received an initial report of a possible active shooter inside Mercy Southwest Hospital. EMS staff immediately responded, with one staff member responding to the command post at the hospital. The remaining staff members responded to EMS headquarters, where they activated the DOC. We contacted all local hospitals advising of the possibility of patient surge and possible evacuation needs of Mercy Southwest. We advised the EOC of the situation and sent a situation report to both CDPH and EMSA at the state levels. We continued to closely monitor the situation until the all clear was given at approximately 2300 hours. On Sunday, July 29th, I received through the MOAC program a request from the state for public health nurses to respond to Shasta County to provide care for people displaced and living in shelters. The public health director was notified, and the information was passed on to the nursing population here at Public Health. 4 nurses volunteered to travel to Shasta County to assist with the shelter operations. The nurses kept in close contact while they went about their assignments, assisting the people of Shasta County. These nurses are to be commended on their willingness to sacrifice to help others. As you can see, our division is constantly changing and striving for improvement. We hope that by expanding our resources and knowledge base, reaching out to our communities and providers, and participating in extraordinary events will help us better serve Kern County. It is recommended that you receive and file this report, and I'm available for any questions.
Thank you, sir. Any public comment, director's report? Seeing none, we'll close the public hearing and bring it back to the board for action or anything. All in favor, say aye. Opposed? Miscellaneous documents for information, EMS, oh, that's already in CA. Board member announcements. Anybody from the board wishing to make an announcement? Please do, Bruce. Thank you, sir. Appreciate it. Any other board member announcements? Next scheduled meeting is Thursday, November 8th, 2018, at 4 o'clock at the, right here. A deadline for submitting public requests for the next MCAB meeting agenda is Thursday, October 25th, 2018, at 5 o'clock to the Kern County EMS Division Senior Emergency Medical Services Coordinator. I'm looking for a motion to adjourn. We're adjourned. Thank you, gentlemen, ladies. Appreciate it.